Let's talk a little bit about how one makes the clinical diagnosis first of dementia, and then how one starts to separate out Alzheimer's from Lewy body, from presumably an unspecified form of dementia. So starting with the former, what is the clinical definition in the diagnosis of dementia?
So dementia is an umbrella term that just sort of describes changes in memory and other areas of cognition. And it represents a change from how you used to be, so you weren't born with it, and it interferes with your day-to-day function. So there are many causes of dementia. Alzheimer's far and away the most common. Although there have been advancements in many of our tests and more sophisticated imaging techniques and blood biomarkers that are coming along, the real crux of diagnosis is a good clinical interview with the patient and with an observer. So usually it's a spouse or an adult child or a loved one who has observed changes over time. In interviewing them separately, that's key, separately, because otherwise the most important information is left out, because they don't want to hurt the loved one's feelings or whatever. So getting a good clinical interview from the patient, informant, doing some cognitive testing to look for patterns that support one diagnosis over another, and then doing some brain imaging to look for certain things like strokes or shrinking in certain parts of the brain, as well as some lab tests to rule out reversible causes of memory loss, thyroid disturbance, vitamin deficiencies, things like that, syphilis, although frankly, I've stopped really testing for that because it's just tertiary syphilis is so uncommon these days. And once we do all that, generally speaking, we have a pretty accurate diagnostic, chance of getting the right, label for them. Sometimes we need formal neuropsych testing with a neuropsychologist. Sometimes we do need PET scanning to look at certain patterns. For example, frontotemporal dementia is one where people often present with relatively preserved memory, but significant changes in language or behavior. And usually, within a minute, I can diagnose them because the loved one will say, well, his memory's not so bad, but, and it's either, he can't really talk anymore, which can also happen in Alzheimer's fairly early in some people, or, I'm embarrassed to take him to church because he'll get up and take the microphone from the pastor, and you almost know, okay, this is FTD. Those are often the people that erroneously get diagnosed with bipolar illness because of these sudden and really profound behavior changes. Problems with judgment where they get labeled as being manic because they're spending lots of money, or they're, responding to every Publishers Clearinghouse thing that comes in the mail. So there's these typical sort of stories and behaviors that we see that kind of support one diagnosis over another.
So Amanda, there's a lot in there, and I kind of want to go over that in a bit more detail. So to make sure I'm understanding this, and obviously the listener as well, the first thing I heard you really say there was the absolute importance of the clinical story. So unlike cancer,
Yes.
where the diagnosis is made typically off imaging and then ultimately through a tissue sample, right? The gold standard is a histological diagnosis. That's not the case in Alzheimer's disease. We don't do biopsies of the brain. I also didn't hear you talk about CSF sampling. Sampling the cerebrospinal fluid to look for amyloid beta or tau. Anything you want to say about that before we continue down this rabbit hole?
Well, yeah, there are a few things I can say about that. First of all, certainly it is extremely helpful in the diagnostic process to have, formal tests like CSF or amyloid PET in terms of confirming the diagnosis. although we certainly don't do brain biopsies, unlike when I graduated, when you literally could only see amyloid at autopsy under a microscope, we now do have the ability to image amyloid in living patients, which has, and I know we're going to talk about research later, allowed us to really go much earlier in the process and design some prevention trials based on targeting people who have brain amyloid but don't yet have memory symptoms. So it's been a really amazing revolution as far as that goes. However, from a cost standpoint, although it's a test I can order, it's not covered by any insurance and would cost a patient about $4,000 out of pocket. So other than doing it, in the context of a clinical trial, it's really not realistic for many of the patients. As far as CSF goes, there is a good correlation between the PET and CSF findings. Because I am a geriatric psychiatrist and not a neurologist, I'm not typically doing lumbar punctures as part of my practice. Generally speaking, between the other markers such as MRI imaging and PET, FDG PET, which measures how well the brain is using glucose as its fuel and has different patterns supporting one diagnosis over another, and that is usually covered by some insurance. We're able to make a diagnosis without the additional marker such as CSF, but there are times when it is helpful and when we do refer people to neurology specifically for that.
So this clinical diagnosis is so important in a way that it's not really as important in the other major chronic diseases, right? When a patient comes in and they're being diagnosed with diabetes or NAFLD, nobody's really taking a great clinical history. You're sort of assuming how they got there. But here you're having that discussion, as you described, both with the patient and with someone who can give some of these details you're looking for. So I kind of want to identify some of these patterns. Now, I guess the textbook cases are first thing is a loss of short-term memory, I'm assuming. Is that the textbook version of Alzheimer's dementia?
Yes. I mean, in Alzheimer's disease, usually people start to complain of forgetfulness, repeating. So a loved one might say, well, he asked me what time this appointment was 4 times since yesterday, kind of thing. But he can remember, all the names of his high school football teammates. That's very classic. So the preservation of long-term memory with difficulty with short-term memory.
Now, Amanda, how do you differentiate distraction from the path to dementia? Because if there's one thing I've heard so often from patients, it's, I just got introduced to this person and I can't remember their name. And it used to be so easy for me to remember names, or, my wife told me to do this thing and I just completely spaced on it. And, in my practice, most of those patients, when they're saying that, tend to be distracted. There tends to be something else going on. It's really not the prodrome to sort of dementia. But obviously in your practice specifically, one can't assume that. Do you have a way that you try to differentiate that?
Well, I think it has to be taken in context with all of the other information. I mean, quite frankly, it happens to me too. Literally yesterday, I thought it was Friday. Because I knew I was normally on Friday, I wear sweatpants and a USF thing, and I knew I wanted to not wear that for this podcast today. And so I was in my Friday outfit yesterday. And so at one point I literally was like, oh, it's Friday. And then I was like, oh no, it's not Friday. But I'm not worried that I have dementia. I was distracted. I'm busy. I have a lot of things going on. And so, all those kinds of things happen to all of us. So it has to be looked at in the context of, the fact that some of this does happen with normal aging. The fact that, stress, a bad night's sleep, all that kind of stuff can affect it. And the other part of it is the frequency and intensity of it.
This podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Finally, I take conflicts of interest very seriously. For all of my disclosures and the companies I invest in or advise, please visit peteratiamd.com/about, where I keep an up-to-date and active list of such companies.